I'm Dr. I.
I'm Dr. J,
And this is Second Opinion with the Twin Doctors, and it is my time. It is time for my favorite part of this episode. Doctor, you know what I want. Give me that news. Give me the news.
I'll tell you what's in the news. There is a study that recently came out that found that drinking instant coffee can make you go blind. Now, before you just toss that cup of coffee, there are some caveats. Basically, what they found was people who have a personal or family history of age-related macular degeneration, if they drink instant coffee on a daily basis, increase their risk of vision loss by 7-fold. So what does this mean? First of all,
do you really need a reason to not drink instant coffee? Instant coffee, horrible.
But if you have a family history of age-related macular degeneration or vision loss, put the instant coffee away. And now for our main topic of the day, womb with a view. Womb with a view. I see what you did. You see what I did there, right? Unraveling infertility. And we've got an amazing guest with us, Dr. Allison Rodgers. She is a board-certified reproductive endocrinologist, and we're super happy to have her on.
Super happy to have her on. Super happy. We're going to keep going.
Have her on.
Poor guy. He had too much instant coffee.
I know. Okay, so infertility rates are rising, and we have got an amazing guest with us today to break it all down. It's Dr. Allison Rodgers, who we've known for years. When we have our really difficult infertility patients, we refer them to Dr. Rodgers. We give her a patient, she gives us back two patients, pregnant mom and baby. She also has an amazing Instagram page that we're going to show you some clips from, and I love to watch it. She's got this one, I'm not going to ruin it. Never mind. Anyway, Dr. Rodgers, she is a reproductive endocrinologist, which is a fertility doctor. She's at Fertility Centers of Illinois, right? Yeah. And you're the lead educator there as well, right?
Yep.
All right, so that means we're about to get educated, guys. So, all right, let's do it. Go for it, teachers.
Okay, so I guess what motivated you to go into REI? What motivated you to go into infertility medicine?
Yeah, this is a great question. So first of all, I love problem solving. I'm sure you guys know trying to figure out problems and puzzles and those kind of things. So that's just sort of what I like to do. But helping people solve problems to become parents, there is no greater joy in the world than helping make families.
Okay.
Yeah.
So, okay, I've got a basic question, but it's probably not that basic. I think a lot of people want to know, because we'll have patients come into our practice all of the time, and they think that, they'll come in and say, I'm infertile. And I'll say, well, what's going on? And they'll tell the story. And oftentimes, based on the definition, at least, they're not suffering from infertility. What is the actual definition of infertility?
Yeah, so infertility is having a hard time getting pregnant or staying pregnant.
Okay, staying pregnant too, and that's
a newer part of the definition.
Okay.
That just came this year through the American Society of Reproductive Medicine. But yes, getting pregnant or staying pregnant for over a year. If you've been trying for over a year. Now, if you're 35 and older, we say 6 months.
Okay. The clock's ticking, huh?
Clock's ticking.
So how common is infertility? Because I feel like I'm seeing more and more of it these days.
Infertility is really common. So it's about 10 to 15% of patients.
Okay.
And about 1 in 8 couples will have issues with infertility. So it's not just your imagination. You are seeing a lot of patients with infertility. I also think that having better access to insurance and better access to care, better treatments. Yeah. I think people are more talking about it a little bit more and seeking care.
So you think that maybe, because we're seeing increasing rates of infertility, do you think that part of this is just that people are more open about it now?
I think that's part of it, but I also think a lot of people are waiting longer than previous generations, right? We think about what were the age of our grandmothers when they had their first kids versus our generation. So I think that that's part of it, because our eggs are on a clock.
Okay.
Doesn't matter how fit and healthy we are, our eggs are on a clock. So if, we run out of eggs, then people become infertile. And as we get older, it becomes harder because we have less healthy eggs.
Mm-hmm. So infertility, obviously we're OBGYNs, so we see it more from the female perspective. And I think that in general, when people think of infertility, they think of it as kind of a female issue.
Yes.
Does infertility affect men and women equally?
So it actually does.
Okay.
So, about 30 to 40% of infertility is mainly female. About 30-40% is male, and then the rest is a combination. And I do think this is a common misperception that, because a lot of stuff is happening in the women's body, right? There's an ovary, fallopian tubes, a uterus, like all that needs to be working. Obviously, there's only one main thing for guys, right? But actually, when we look, about half of guys have fertility issues.
Who was that king? Was it King George who kept killing the wives who couldn't give him babies?
King George.
Was it King George? Was it King George? I think it was King George. I'm not a historian.
King Henry.
I think you might be right. Maybe King Henry.
Yeah,
that's right.
Who
King
had
Henry
his
VIII.
6 wives.
That's right. He kept killing them because they couldn't give him kids. And
Yeah.
now I wonder if King Henry wasn't the problem.
I think King Henry was the problem.
He might have been
Yeah, I
the
bet he
problem.
was. Yeah.
You kind of touched on with people waiting later. Is that the main reason why we're seeing more infertility, or is there more to the story?
I think it's multifactorial for sure. I think part of it is people waiting longer. I think part of it is people being more open to treatment. I certainly think part of it is better successful treatment strategies.
Okay.
And you do wonder about some other things, right? Like environmental.
Yeah, that's what I'm thinking. Environmental, lifestyle, things like that.
Yes. And as healthy as we all try to be, we are all, no matter how healthy we are, exposed to toxins in our environment. And these can be things we consume. These are things that we can breathe in. These are, our regular shampoos and lotions. Right. Hormone disrupting things that we're exposed to. So I do think that for some people has a role.
And I'll tell you, when you go down that rabbit hole of the chemicals that you can be exposed to, that can affect both not just fertility but health in general, it's astounding. I mean, nonstick cookware. Right. Like you said, the shampoos, the lotions, carpeting, plastic.
Upholstery.
Yeah.
Upholstery.
Mattresses.
Yeah, mattresses. Anything that's got flame retarding on it.
Right.
Yeah, it's going to probably retard your...
Hopefully we all have mattresses.
Yeah.
So I'm just going to go live in a tree in the forest to call it a day.
I mean, everything, so it's just important to be aware. I mean, obviously you can only do so much.
Yeah. So what are some early signs that either you may have issues with fertility or issues may be soon to arise?
So I think that on a female side, looking at people who have irregular cycles. So if your cycles are not coming at least every 35 days, I think you might not be ovulating or ovulating in an appropriate way. I also think people who have really serious pain with their periods may have endometriosis. People who, have excessive bleeding may have anomalies like fibroids or other structural problems that could be causing heavy bleeding.
Yeah.
On the male side, the main thing that we see is issues with sexual function. So difficulty with erections or ejaculation, difficulty with performing sex. If that is an issue, then it's probably a good idea to get evaluated.
And I was just going to say, when you say painful periods, it's funny too, because that's so subjective, because I've had patients that I've seen, not necessarily for fertility issues, but other issues, and we find pathology and I'll say, are you having painful periods? And they'll say, yeah, but I just...
They've always had painful periods.
They say,
I think that's normal.
Yeah, and so I guess, and this is probably a tough question to answer, but how do you...
Quantify or...
Not quantify per se, but what would you tell a woman is... And this is probably a tough question.
Too much.
Yeah. How do you tell them this is normal discomfort and this is potentially an issue?
Yeah, so I think if you're somebody who maybe on your second happiest day of your cycle needs to take a little Advil, but you can do your job, you can go about your day, I think that's probably normal. If you're somebody who's having to take medication, it's not working, it's pain is waking you out of your sleep, or you can't go to work, you were going to meet up with friends and now you can't because you're in so much pain, it's disrupting your life, that is not normal.
And it's funny because I feel like oftentimes women don't necessarily like to endorse the fact that their periods are so painful that they're debilitating. Because the reality is, I've had patients come in and your human nature thinking like, really? Is it really that bad, And then you do maybe a diagnostic laparoscopy. And I had a patient once who had grade 4 endometriosis. I mean, she had it horrifically. And before she came to me, she was on narcotics during her period. And she said that when she would request them, people kind of looked at her, they thought she was drug seeking. And that made her kind of ashamed to admit that she was suffering like she was.
Gosh, it's almost embarrassing as physicians, right? Like to hear stories like that where people have maybe been not taken seriously or gaslit to thinking like this is normal when it's not.
But the reality is, and I think obviously you're a woman and we're in women's health, I feel like that happens with women more in general. Right?
Absolutely.
Like, it's not that bad. It's okay. Just deal with it. And not just from the medical community, but from other people as well. Like, our patients are in labor. Their mother says, you can do this. You don't need that epidural. We've never had epidurals. I feel like just in general, women are forced to deal with more pain, more discomfort than men are. So I don't know. Yeah.
But no, I think, women are the caretakers. Women are the caretakers. In general, women are the caretakers, and so they're always kind of putting their issues on the back burner, taking care of everybody else. And I think that when they actually speak up and they voice issues, it's like, well, never complained before. Yeah, exactly. People don't necessarily know how to receive it. So, okay, go ahead.
When should people come to see you? Like, I know you said 6 months of trying if they're over 35, a year if they're under 35. Is that the absolute rule, or can they come earlier? Can they wait later?
Great question. So I think if you are, like, for example, if you haven't hit your time of trying on your own, but your periods are really painful, they're really heavy, you're having trouble with intercourse, maybe you're not getting regular periods, certainly right away.
So it kind of alluded to it, but when it comes to infertility, what are the main culprits in men and women that lead to infertility in most cases that you see?
So for women, we think about the main things that were needed for fertility. So ovaries, fallopian tubes, and the uterus. So from an ovary perspective, I think about anything that is causing you not to ovulate or anything that's causing abnormal eggs. So things like polycystic ovary syndrome. Sometimes people have what we call diminished ovarian reserve or ovarian insufficiency, where people lose their eggs earlier than they should. So from a fallopian tube perspective, a lot of people don't even know they have fallopian tube issues, right? They're not having any symptoms from it. And so that's a situation where we can do testing. We can either do special ultrasounds or x-ray testing to see if the fallopian tubes are open. And then from a uterine perspective, things like fibroids, polyps, endometriosis, those kind of things can certainly cause issues with fertility.
And good question. I'll have patients come all the time and say, I want to see if I've got eggs.
Yeah.
How do you do that?
So it's actually easier than you think. So there's a couple of different ways we can check somebody for eggs. The biggest predictor of successful eggs is age. So that you can tell just by looking at down Saturide. But from a hormone perspective, a lot of times we'll check a hormone called AMH, or anti-Müllerian hormone. And we've been using this hormone for years, and it's a hormone that comes from the resting eggs inside the ovary, and we can actually see, sort of if your eggs are in a normal range. Now, we can't say you have 1,000 eggs left. We can say this is normal for your age, low for your age, or high for your age.
But there's a correlation.
Absolutely.
Okay.
And then, from the male perspective, obviously, semen analysis is one of the first steps.
Absolutely.
And on your Instagram page, you do the Sperm Mondays.
That's right.
You do the Sperm Mondays, where you basically kind of go through a semen analysis. So we're actually going to show one of those now.
Perfect.
Because I'm sure when people think of semen analysis, they're thinking like, what exactly are you looking for? So this video will demonstrate just that.
I seriously feel like I find these every day. This sperm is swimming in circles. One of my favorite abnormalities to watch. I'm not sure why, because clearly it can't get to an egg if it's just swimming in circles. Wrong way. There's some agglutination here where these guys are stuck, but this one, just doing his own thing, swimming in circles, chasing his own tail. We see this commonly as an abnormality where sperm just swim in a circle. This is abnormality with the forward progression. Obviously, they can't swim to an egg if they're swimming in circles.
So I love how you were focused on that one little guy that just kept going around in circles.
Those are my favorite.
I was rooting for him. I was like, come on, get it together. Anyway, yeah.
Okay, so we think of a woman's biological clock, right? Menopause happens, no more babies. But people think that men can go on forever into your, if you want to, 60s, 70s, 80s, 90s having babies. Does a man's fertility diminish as well? And if so, why?
So yes and no. So it is true. Women are born with all the eggs they're ever going to have, and we lose them throughout our lives. Men, they keep on making sperm. So theoretically, you can make sperm your whole life, even into old age. That being said, there's a lot of medical conditions that can lower sperm quality. We think about things like diabetes, for example, that can have significant impacts on the health of sperm. And we do see some genetic disorders go up with advanced paternal age, so the advanced age of the father. So these are autosomal dominant disorders. We think about things like there's a condition called achondroplasia, which is a, autosomal dominant disorder that we see sometimes in advanced aged men. But yeah, semen analysis can go down as men get older.
So sperm quality, does it automatically get worse with age, or is it if there's other issues present?
Usually if there's other issues present, but most of us collect issues as we go through life.
I've got another. We go through life like we're in a, exactly, you're right about that. So, okay. I feel like one of the probably easiest factors that people can modify that they can improve their fertility is weight.
Yeah.
How big of a factor is weight in causing infertility?
So a lot of times weight affects a woman's ability to ovulate normally. Okay. And so even if you're underweight, you can have issues with not ovulating because your pituitary gland is like, I'm starving, I can't support a life, and it shuts itself down, right? I also think that being overweight can sometimes extra fat cells create extra estrogen, and it can disrupt the way our bodies ovulate. Not for everybody. There's certainly people who are overweight who are able to ovulate, but for a lot of women, carrying extra weight can decrease ovulation. So that's part of it.
Is there a certain BMI
I
range?
was gonna say, is there an ideal BMI that you want to be in? It's hard to say, but for optimizing fertility?
Normal is normal. I mean, the more normal you can get, the better.
Say, why
right?
complicate it, right?
I mean, the more normal you can get, the better. I will say that sometimes we know BMI isn't a perfect marker, right? So we know there's people who are fit and muscular and have like a good, body composition, and their BMI is high because they have a lot of muscle, right? So I do think we have to be sort of careful about just using like a marker like that. Obviously, there's differences between different people. And then with men, we also see weight can be a problem. So fat cells create extra estrogen. Men who are heavier tend to have poor sperm numbers.
So I could have gotten out of making babies just by getting fat.
It's not too late.
Where were you?
Not too late.
years
It's not
ago?
too late. So what about other lifestyle factors? Stress, diet, alcohol values, things like that.
So stress is hard because everybody has stress.
Stressed.
Anything you can do to sort of minimize stress is good. So, taking care of your mental health is always super important. From another lifestyle perspective, minimizing caffeine is one. Most of us drink caffeine.
You lost me.
I know. So under 300 milligrams. So I usually recommend no more than 20 ounces of coffee a day. I always tell people if you're doing half caff, you could do 40. Limiting nicotine, limiting marijuana. Now, certainly edible marijuana is going to be safer than anything inhaled, but marijuana can play a role in sperm health.
And is it just the THC, or what about folks that use, CBD?
So that's a hard question. I don't think it's truly been studied. CBD doesn't really cross that blood-brain barrier, and so probably doesn't have as much of an effect. But we know that, some men seem to be very sensitive to marijuana. They're using very little and seem to have huge improvements by stopping. Some men, it doesn't seem to affect them. And then actually there's some medicines that men take that can dramatically affect their sperm that are doctor prescribed. Okay. So, we think about certain medications for like testosterone replacements. That's a big one. So people who are on testosterone replacement for low testosterone, which is a very, a lot of men have it. It's no fun to have low testosterone if you're a man. And the testosterone that people take actually shuts off the testicles.
And I think people don't know that, like those commercials, been shown a little bit too, and not if you're trying to have a baby. Like, I don't think people think that more testosterone will actually increase sperm count. It's actually the opposite.
Yeah,
it's the opposite.
It is more or less like male birth control.
Yeah. Ooh. I wish I knew. No, John. Okay, so when people think of reproductive endocrinology, I think they think of IVF. So I want to talk about IVF really quickly. Can you quickly tell people what does the process look like?
Yeah, so
the Cliff Notes version.
Cliff Note version of IVF is we give medication to help the body grow a whole group of eggs. Now, those are eggs you were going to lose anyway that month, so it doesn't take away from future fertility. We then do a procedure. It's a 10 to 15 minute procedure with a small needle while you're sedated so you don't feel anything, where we collect the eggs through the vagina. We use a needle on an ultrasound guide. We fertilize the eggs, grow them in the lab, and then we can either put them back into the woman's body 5 days later, or we can freeze them. A lot of times we're able to do genetic testing to make sure the embryos are healthy.
But what happens during an IVF egg retrieval? This might look like a bunch of just gray and black blobs, but I want to go over what we're doing and why we're doing it. The uterus is on the left of the screen and the left ovary is on the right of the screen. We can see a needle here going into each follicle. Those are the sacs that contain the eggs. This patient does have an unusually large number, and very carefully going into the follicle and draining the fluid. Now, each follicle should have fluid plus an egg. That fluid is then drained into a test tube, and the embryologist looks under the microscope to find the eggs. This procedure is done under sedation and typically takes about 15 minutes. You can imagine that around the ovary is bowel, uterus, blood vessels, things we don't want to hit with the needle. It takes precision and expertise. Do you see this little loop of bowel trying to sneak in between the ovary and the uterus? When we're done, the follicles fill up with blood like a bruise. This is what it looks like when we are done, hoping these eggs go on to make a baby.
How much does it cost?
So, it's interesting. So I practice in Chicago. About 85% of my patients have coverage, which is amazing. Now, this varies dramatically
I would imagine.
by where you are in the country.
Okay.
But I think, so it's very variable. But I would say that, like, in general, the range of IVF is probably going to be in the $12,000 to $18,000 range.
Is IVF the only answer? Like, everybody assumes if they're seeing a reproductive doctor, they're going to get IVF. Is that all that's available, or
actually we do lots of other treatment? So there is all kinds of options. So for people who just aren't ovulating, we can give them ovulation induction. So these can be as simple as like a couple days of medication to help the ovary do its job. We can do inseminations where we put sperm inside the uterus. That you're awake, it's very minimally invasive. So there's a lot of less invasive treatments that we can start with.
Okay. Where can people find you?
So I am
Monday.
For Sperm Mondays, I'm at dr.allison.rodgers, and I on Instagram and TikTok, and then I'm at Fertility Centers of Illinois, so fcionline.com.
Awesome. All right, well, thank you for joining us. We're gonna have to do this again. I had a lot more I wanted to go into.
So many more things.
Okay, so that was an amazing infertility talk we had with Dr. Rodgers. Now we wanted to switch it up a little bit. We wanted to talk about the use of yoga and helping to promote fertility. And what motivated me to want to do this was there was a journal article that came out in 2018. I think it was the Journal of Complementary and Alternative Medicine, where they looked at the use of yoga and helping to promote fertility in patients undergoing infertility treatment. And they found that patients who did yoga had better results across the board, no matter what the treatment was that they were undergoing. So I said, okay, we've got to try a little bit of yoga. I wanted to do it for the longest time anyway. I'm not very flexible, I'm sure you can tell. Are you trying to boost your fertility? Something you want to develop? No, I'm not. No, I'm not. So we've got an amazing yoga specialist with us, Molly. I don't want to butcher your last name. Kranovich.
Yeah.
Molly Kranovich. She's from Lumi Studios, and she's going to show us how to do some fertility boosting yoga poses. So first thing I wanted to ask you about was, I read that certain poses basically help to increase blood supply to the pelvis, and that in doing so, that can help with fertility, both in terms of helping you to ovulate more effectively, but also helping with implantation. But I also read that certain poses can help to strengthen muscles, which can also help with sexual function. I read these poses. I don't know what any of those poses are.
But he's very interested.
Oh, but I'm very interested. Exactly. Yes, can't you tell? So, please tell us, what can we do to boost our fertility and our pelvic health?
Well, one of the reasons I think yoga helps with this is because it helps to regulate the nervous system and calm us down, right? In a time when infertility is super stressful, right? So one pose I thought about showing was a supported bridge, which is why I brought our blocks today. And so, like a typical bridge pose, you're gonna start on your back and you're gonna grab that block on the side.
Bridges, I was going.
You don't know the bridges? Okay.
No, I don't.
And you're gonna plant your feet into the mat. You're gonna lift up those hips and tuck the block under the lower back.
Isn't that cheating?
It's like cheating, but you know what? You can't do infertility without support, right? For short of your doctor's support of the block. So here in this pose, this will allow the blood to flow to the pelvis. It'll allow you to feel supported here. And this is a good practice for some breathing too. So that's one pose I thought we would share.
How long should they do?
You know what? You could do it up to 5 minutes, but even a couple rounds of breath here would be great. This is something we often do towards the end of a yoga practice, but you can do it just on its own too.
And I do feel the blood flowing to my pelvis.
And then another option would be to take your legs straight up here.
Now you're getting hard, okay.
This you could do against a wall, legs up the wall.
My leg's shaking.
Yeah, we can put it back down just for a second. But that'll help the blood flow to the pelvis too. So then you're gonna release that block, take it by your side, roll on down. We can sit back up. That's one pose.
All right, nice. Okay. Now there was another pose I read. Cobra.
Okay, so Cobra is going to be on your belly. So
Okay, all right. That's what I was planning to do.
So you're going to go on your belly here. You're going to take your forearms out. Breathe into the little back bend here. Yeah, lift on up. Breathe. Look forward. You got this. There you go.
Oh, this is it.
Yeah.
Okay. And how long do you normally hold this pose?
I wouldn't hold. Maybe you want to push into your hands, lift up a little higher, Cobra here, but I wouldn't hold it.
You had mentioned breath work. Do you do breath work while you're holding the poses, or is breath work something you do before, after, or?
Let's head back to our seat and I'll show you. So when you're in a yoga practice, often you're doing one breath, one movement. So you might do something like where you're going to inhale up and exhale as you twist or something like that. But I like to start all my practices with breath work and end them with breath work as well. And I think that helps to kind of check in with our body, which I think is an important practice as you're looking at this. So for example, we might start seated like this. I might offer you to have your palms up to take a soft gaze, maybe, or close your eyes if it's comfortable. And then just check in with the breath. Notice, where do you feel it? Do you feel it in your nose? Do you feel it in your throat? Do you feel it in your belly? And as you breathe in, can you fill your stomach with air? And as you breathe out, can you let it go? And then maybe even anchoring that with a word. Can you breathe in the idea of letting and breathe out go? Or breathe in calm and breathe out whatever's not serving you today. And then I often ask my clients to check in with their mindset. How are they feeling that day? Notice if their mind's racing or slow, that kind of thing. So just kind of being aware.
Do you think that actions like breath work are successful because they lower stress hormone levels?
Yes, yeah, I do think so. I think it helps regulate the nervous system, like regulate the hormones, yes.
Is there a time of day that's better? Should people start their day with this, end their day with this?
All the time. You're driving and you're anxious, like you're mad, you're in road rage, take a deep breath,
Just
right?
don't
It's
close your
always
eyes. Just
gonna
don't close your
happen.
eyes.
Yeah. Or I teach kids to use their fingers and touch their fingers if they're, before a test or anytime. Yeah, but I think anytime. But I mean, it's also maybe your mind is racing at night and that's when you're thinking about your infertility struggles. Taking a deep breath isn't going to hurt, right? It's not going to make you pregnant right away, but it's not going to hurt.
And oftentimes you really do get kind of into this emotional cycle when you're dealing with infertility because you're dealing with the infertility, you feel stressed. Stress causes you to make cortisol, the stress hormones. The stress hormones affect how you ovulate in your fertility. You have more issues with fertility, you feel stressed, and you kind of get into this cycle. And activities like this just allow you to kind of detach from it, I think.
Yeah, I think so too. And I think often people can blame themselves when they're in an infertility process, right? And so sometimes things like yoga can be hard to do because you have to sit with those thoughts. But I think it can really help to kind of rewire that and help you learn to trust your body again and to listen to your body and what it's telling you.
So it sounds like almost. Go ahead.
I was going to say, any other poses that you think are good for fertility?
I think child's pose is a good one too. So in child's pose, you're going to bring your toes together, take your knees wide, shift your hips back. So you reach on out, maybe take your forehead towards the mat.
Oh, this is good for the lower back too.
This is good for the lower back. Good to find your breath, to kind of close yourself off. Just taking a few breaths here. I would recommend child's pose as well. Good form, guys.
Thank you, Jess, but thank you so much. Very kind. Honestly, think it's worth I've ever seen.
Yeah, I know. She's gonna say those guys are pathetic. But it's thank you so much for doing this. This was really amazing.
How can they find you? How do people find you?
You can find me over at Lumi Studio and Shop. We have a yoga studio, retail shop. We have 50 local makers, including these yoga mats made by a local artist.
Social?
Yeah. And so build Instagram at Lumi Studio Shop.
Great.
Yeah.
All right. Well, thank you. We'll do this again real soon.
Yeah. Thanks.
All right, guys, this episode is almost finished. However, before we end this episode, it is time for one of my other favorite segments. I guess I like them all. RX TikTok, prescription TikTok.
I got the craziest skin on my leg. Like, I got regular skin here, and then I got this shiny reptilian. I have no idea why it's like this.
If this is you, I have bad news. You need to listen to this. It's very likely you have an obstruction of blood flow going into your leg, maybe even both legs, and you need to see a doctor immediately. The lack of blood flow causes the hair follicles to fall out and the fat to atrophy, causing a hairless, shiny appearance. An even bigger problem is that if you have this plaque building up in your legs, it's also building up all over your body, including the heart and the brain, and a heart attack or a stroke could be imminent.
That's right. So basically, if you have shiny, hairless legs, your risk of heart attack and stroke is increased by 90%. He's got hairless legs, but they're not real shiny yet. So, shiny, hairless legs, especially if it's rapid onset, go see your doctor. Risk of heart attack and stroke is high. With that, guys, this appointment is now done. But don't ever, no. Go to the waiting room, check in with the receptionist, and make your appointment for the next episode of Second Opinion with the Twin Doctors. I'm Dr. I. I'm Dr. J. See you soon.